we will speak about the surgical operations which we perform inside of the peritoneal cavity. I want to say you guys that from all branches of the surgery, abdominal surgery is the biggest branch. Approximately 60% of all surgical performances we make inside of the abdomen. That is all abdominal compartments on the walls, which has very important surgical problem, which is called the hernias. By the way, as you remember, this problem we have an anterior and posterior wall. Yeah, we have so-called lumbar hernias, and of course, much more important surgically, we have the problems of cavities. Mainly, predominantly, it is the peritoneal cavity, but not less important. It is the retroperitoneal space with the organs which we have here. And today I will speak about especially the peritoneal operative surgery, and we will discuss the problems which we have inside of it. Now, which kind of the surgeries we make inside of the peritoneal cavity? Generally, it is the 5 groups. You can write, please. The surgical performances inside of the peritoneal cavity can be divided into the 5 groups. Group number 1. It is the opening of the lumen of the whole organs. In the Latin, we call it the Tomy surgery. For example, gastrotomy, intestinotomy, colotomy. Then we open the lumen and remove something or take something from the lumen. By the way, we can write or remember it can be the curative surgery or the diagnostical surgery. Especially I want to say that tomical surgeries is very usual for the oncological practice. For example, to take the biopsy for the investigations, yeah? Or to remove some obstructional structures. That's a very widespread problem. Now write please, second surgery we call a resectional surgeries. Resectional surgery. Resectional surgery, it is portional removing of organs. Portional removing of organs. For example, you know, the resection of stomach, resection of small intestine, resection of the large intestine. By the way, many attention to me, guys. In majority of the cases, this is the curative manipulation. That's how we remove something pathological. For example, we remove the part of the intestine with the same tumor, and we make the curation generally. But it can be palliative manipulation, yeah? That there are the big, huge pathological problem, completely you cannot remove it. So you make the portional removing of it, for example, to decrease the pressure into the neighboring structures. Let's imagine, yeah, for example, there are the big tumor inside of retroperitoneal space, which is press aorta abdominalis and inferior caudal vein. I can't completely remove it because of the metastasis, but I can portionally resect it exactly in the level of the big vessels, yeah, to prevent the huge pressure of them. Let's say, remember, please, once again, we can have curative modality or we can have palliative modality. Now, write, please, the third variant, it is the removing of the whole organ. Removing of the whole organ. We call it ectomy, you remember, like the gastrectomy, colectomy. And you understand that mainly and predominantly this is the curative manipulation. That's like we maximally big remove some pathological structures. Of course, you understand that such kind of the surgery is very traumatical. And second, what is necessary to remove, remember, in majority of the cases, you must make reconstructions. If I remove, for example, stomach, I must make here some reconstructive surgeries. For example, to take the part of the large intestine and to try to modify and reconstruct here the stomach, artificial, of course. Right, please, the surgery number 4, if I don't mistake, yeah, it is the formation of anastomosis. In the brackets, right, please, otherwise we call it recanalization. recanalization, formation of anastomose. 1 minute attention to me. Anastomose performed after any resectional surgeries and the complete removing of the whole organs. Let's say that you remove some part of the gastrointestinal tract, you must after to connect the upper and lower compartments to each other, yeah, to make the recanalization. For example, you remove the duodenum, now you must to connect the stomach with the jejunum. So you should apply the anastomose between these two structural units. That's a very usual, very widespread form of the surgical performance. By the way, again, it can be and curative and palliative. For example, let's imagine the curative modality of the surgery with necessity to perform anastomose between stomach and, for example, between the duodenum in pyloric portion, we have the tumor. This tumor is removable. So I will make resection of the pyloric part of the stomach, and then between stump of the stomach and duodenum, I will apply end-to-end anastomose. This is the curative modality. Now, the same pyloric part has the tumor, which is unremovable. And I will take now the jejunum and will apply the side-to-side anastomose between the greater curvature of the stomach and jejunum. You imagine it? There's a food from stomach now immediately will go to the jejunum, but the main disorder will not be removed. So this is important to remember. That's a formation of anastomose we can do, and like the curation and like the palliative modality in the abdominal surgery. And finally, last fifth, most usual one, it is formation of stoma. In the brackets, right, please, otherwise it is the fistula in the whole organ, which connected it with environment. Fistula with the whole organ to connect it with environment. Now we need attention. Let's again understand what does it mean. Again, guys, I must inform you that it can be palliative and radical method of the treatment. If it is radical treatment, usually it is one step in many steps surgical modality. It means I cannot perform my treatment only by one surgical performance. I should do several surgical performances, and one from there it is appliement of the stoma. What is generally meaning of these stomas? To make decompression inside of the intestinal lumen. For example, there are something like this. Something like this, yeah? This is the tube. Tube is obstructed. Above obstruction, we have dilatation. Below obstruction, we have vice versa. Yeah, absolutely empty intestinal lumen. Now, I remove this obstruction. I make the resection. But you understand that now these two parts is not congruent to each other. If I will try to apply now anastomose between them, I will have insufficiency of the sutures. Let's say usually I will close this distal end, proximal end I will open to outside, I will apply so-called stoma. I will wait, for example, several days until I will have decompression here. Feces will come to outside, size of the lumen will be decreased. By the way, during that time I can make, for example, parenteral feeding of the patient to have the cleaning of the intestine, yeah, to make maximal decompression of it. And then by step number 2, I will apply anastomose, yeah, different kinds. Today we will study, we will speak about it. So remember, please, in majority of the cases, this is more than one step, yeah, double step, triple step type of the surgery. If it is radical method of the treatment. What about palliative method of the treatment? Samely, there are here obstruction, but now this obstruction is unremovable. Above the place of obstruction, I will apply the stoma to outside, especially in the large intestine, yeah, and I will have the formation of anus proternaturalis. Otherwise, I will open the new anal aperture, and feces will come to outside from the anterior abdominal wall. That's it. It will be palliative modality because main problem will not be resolved. but I will prolong the life of the patient and will make it more comfortable. Let's say, remember please, that we speak about the peritoneal cavity surgeries. In predominantly, mainly, we mention these type of the surgical performances. There are exceptions, of course, but mainly, for example, we can have heart plastical reconstruction on the vessels, on the lymphatic structures. Yeah, it's also possible, but mainly, predominantly, it is this 5 group of the manipulation. Now, right, please, hold these 5 group of manipulations. We do using special kind of the sutures, which is called intestinal sutures. By the way, you can write or you can remember that intestinal sutures apply in gastrointestinal tract organs, starting from esophagus and finished by the anal portion of the rectum. Let's say then we say intestinal, it doesn't mean that we apply it only in the intestine. Starting from esophagus up to the lowest part of the gastrointestinal tract. And these sutures, guys, we need attention to me, must to have some specific qualities. And these specific qualities now we must to describe. Right, please, the main principles of intestinal sutures. And number 1, right, please, they should be hermetical. In the brackets, right, please, it must to have physical and biological hermetism. And let's discuss now what does it mean. Normally, guys, our intestine contain absolutely non-sterile content, but in the same time it forms the barriers which is prevent passage of this content to peritoneal cavity. Your peritoneal cavity is sterile environment. Now, so interesting, yeah? Inside of peritoneal cavity, we have non-sterile gastrointestinal tract, but the wall of this gastrointestinal tract prevent any passage of infection from inside to outside. By the way, from that point of the view, I want to remind you your histology. As you remember, first 2 layers of intestinal wall, which is the mucus and submucous, it is infected layers. Means inside of these layers, we have the microorganisms, different kinds. Gram-positive, gram-negative, pathological, and non-pathological, but anyhow, it is non-sterile. Last 2 layers, that is the muscular layer and this serous membrane, doesn't contain any microorganism. Let's say this is sterile layers for us. And due to the specificity of the wall structure, we have complete separation of internal and external environment for the intestine. And then we speak about hermetism, and we mentioned that we must have unmechanical and biological. It means that we must to prevent formation of any mechanical connections between internal and external. But more of this, we must to prevent the passage of the microorganisms, because maybe visible defects we will not have, but we will have invisible communication. You understand, so small size have the microorganisms. And of course, any micro connections will be enough to send young microorganisms from inside to outside. That's a little after I will speak about how to achieve this hermetism. But now remember, please, number 2, they should be mechanically strong. Let's say they must to provide durability. But here there are one problem, guys. Now, we need attention to me. If it is possible, friend, apply your fist like this. Now, I connected these 2 margins to each other. Yeah. Now look, how much I will apply the force to make this connection. Thank you very much. How much? 1 minute attention. Sometimes you think the more will be the force, the better will be result. Of course, no. Or you can say opposite variant. Let's not apply the big force to be collided by these margins. Both situations and both ideas is absolutely wrong. Now look, then I say mechanically strong. What does it mean? It means these 2 margins should have very good attachment to each other, but not more than it's enough. It means I will make connection, I will make the attachment, but I will not apply so much force to cut the margins of the intestine and to come to outside. Let's say two problems I can have. Problem number one, if my force will not be enough, margins will not normally attach to each other. I will have defect. Problem number two, if my force will be more than enough, I will cut the margins, or I will make strong compression of the margins, and it will give a big problem. Let's say then we say mechanical strong. It means logically enough strong, not the more strong the better. So you need to make the attachment of the margins, because only if they will touch to each other, I will have the normal regeneration. So margin should be absolutely connected to each other, but not more. Idea is understandable for you guys. Let's say, of course, you need to have some experience. You must to feel by your fingers how much force it's. I cannot say now by kilonewtons or some other measurement, some modalities, how much force you will apply. You will apply force which is enough to connect these margins to each other. Idea is understandable for you. Right, please. Point number 3. The sutures must be minimally, let's say, problematical for the lumen of intestine. They will not critically decrease the lumen of the suturing whole organs. They will not critically decrease the lumen of the suturing organ. What does it mean? Now look to me. For example, with my fingers, this is the margins of the whole organ, which I want to suture to each other. Now look everybody here. Of course, you must do your best to prevent exvagination of intestinal wall in the place of the suture. Tell me why.
Because of the bacteria is present in the...
Because the mucous membrane, as I said before, is not sterile. That's why if I will have exvagination, in that place I will spread infection to all neighboring structures. That's why, unfortunately, from that point of the view, I must make invagination. Why I say unfortunately? Because any invagination, as you can see, decreases the lumen. And the more I will invaginate the wall, the more smaller, finally, lumen will be in the place of my suture. But I don't have any other chance. That's why remember, please, this is unremovable surgical problem. Any sutures of intestinal wall decrease the lumen of it in this place. And usually, guys, one suture line decrease the lumen approximately into the half of centimeter. Because your piercing distance, as you remember, it is the distance between the hole formation and the margin of the suturing structure. Yeah, it is near of the 0.23 centimeter from both sides together. It will be half centimeter. Let's say, remember, please, in the future you will see that in suturing we apply not one but minimum 2 lines of the suture. So finally, if you will apply 2 lines, means 1 invagination and second invagination. Finally, you will decrease the lumen of intestine approximately to 1 centimeter. Now you can say me now, but what to do in this case? Now look to me. Let's imagine that primary, the suturing place doesn't have so big lumen. For example, it is duodenum or it is jejunum. Normally, guys, the diameter of this structure is near the 3 centimeters. But remember, please, 2.5, 3 centimeters, it is the critical smallest size of anastomosis. If anastomosis will be less than 2.5, 3 centimeters, there are high chance of formation of obstructions. So I must to do my best to form the anastomosis, which is not smaller than 2.5 centimeter in the diameter. Otherwise, in the place of the suture, the lumen should be approximately near the 3 centimeter, 2.5 and more. Now, what can I do? In the future, you will see, guys, we have special techniques. For example, if I cannot connect it 2 rings to each other, I can connect it 2 sides to each other. I can form not only anastomose end to end, but I can make anastomose side to end. And in that case, of course, the problem of communication between rings will be secondary because I will cut the sides, and I will cut the sides how I need, to not have any insufficiency in the future in the connection place. It is understandable for you. That's why this is very important point, guys. Remember, we must do our best to not critically decrease the size of the suturing place. Is it possible for you to come to me? You. Hurry up, please, because time is very short. Can you connect your hands, stand up here, in such a way, to have attachment of the margins of your white coat? It doesn't matter, it will be white coat or what. Now, inserted one hand into the, yes, I need to have something like this. Now look to me. Now, for example, this is the place of our connection, yeah, communication. Now, what the problem here? As I say you, I will apply minimum 2 layers of the suture. That's why I will have decreasing of the lumen of anastomose here. How usually surgeons check size of this communication? From the wall, not from the lumen, after applying of my anastomose, I try to connect it, my 2 fingers, to each other through this apply aperture. I do it from the wall, not from the cavity. Cavity is closed. If my fingers connected to each other, it means minimum size of connection, it is 3 centimeters. Because my fingers, it is more than 1 centimeter, usually for any peoples, males, females. And the walls, which is between my fingers, together with my fingers, forms approximately communication, which is equal to 3 centimeters. So if I can connect the tip of my fingers from this applied communication, it means it is enough for the passage of the content. Touch wood, if I can't connect my fingers to each other, it means I apply anastomose, which possibly can give obstruction. I should destroy it and apply another anastomose. By the way, samely I will make detection in case of side-of-side anastomose. No any difference. Again, from the wall, I will try to connect my fingers to each other. It is understandable for this. I must have some logical minimal size of communication. If communication will be less, we can have the big chance of formation of obstruction in this region. Continue, please. Next point. Sutures should not damage the arterial supplyment and the venous drainage of intestine. Will not damage the supplyment of intestinal wall. This is, guys, very important rule. Now, 1 minute attention to me. For example, this is the place of your suture. For example, again, anastomose. I can put, for example, another example, not anastomose, but there are told. What is important here, guys, to remember about the distance between 2 sutures, which is called suture stem. If you will apply sutures very far from each other, you will have possible connection between peritoneal cavity and intestinal lumen, passage of infection. But it doesn't mean that the more near will be sutures to each other, the better. Because if you will apply now these sutures very near to each other, you can close all vessels and nerves, which we have in the place of the future regeneration. So they will not have any enough place for the regeneration. That's why I will tell you after about suture step. By the way, remember again, 0.34 millimeters means centimeters, 34 millimeters. That's why it is the necessary enough distance for the regeneration of the vascular structures. If it will be less, the chance of the pressure and destruction of the vascularization will be very high. Next point, right, please. Suture should be maximally maximally aseptical to prevent any passage of the infection. One minute attention to me, guys. What does it mean? Suture line by itself should be sterile. What is it? You can say now, sir, I applied a beautiful suture. In the place of the suture, no any holes. Mucous membrane doesn't look to outside. It is invaginated. And is it enough or no? I will say you no. That is not enough. Why? Because then you take the needle with the thread and perforate it, for example, all wall of intestine from outside to inside, and opposite one from inside to outside. By the passage of your needle, internal infection come to outside. And line of the suture by itself, even without any apertures, even without any exvaginated mucous membrane, can be infected. Because your thread and your needle perforated infected layers of intestine. It means mucus and submucous membrane. If we have contact with infected structures, we must to mention that all our suture line is infected. And we must to do some modalities to prevent, because, for example, my hand, it is the suture line, yeah? Everything which is touched to this suture line will have the chance to be infected. This is contact-agenious infection. So that is necessary to remember, guys. Any suture line which is contact with internal layers have the chance to give the infection. Now you can say me, but what to do in that case? Idea is simple, and little after you will see it. I connected two margins to each other. Of course, my line, it is infected because my needle passed through the infected layers. What can I do? I must to close it now from outside by sterile suture. Means second my line will pass only through the two sterile layers. Means muscular and serous. It doesn't contact it with infected structures, and it is completely invaginated infected line and close any communication of it with the neighboring structures. Do you understand me or not? That I look now to my fingers. That is first line. It makes the small invagination, but now this place of attachment is infected. Because my thread pass from the infected layers. What should I do? I should apply second line. Of course, I will decrease the lumen of intestine, but I will completely close invaginated, infected suture line. Now, if she will touch to this place of my suture, she will not be infected. Because second, my suture layer completely separated infected line from any contact. Do you understand it? By the way, little after you will see that for stomach and small intestine, we use predominantly double suture lines. For large intestine, the most preferable type, it is triple suture line. Let's say infected line, we close twice. Because we know that content of the large intestine is much more aggressive. And if it will come to outside, of course, formation of infection will be much more easy. Is it understandable? Now, right, please, to achieve the upper given goals, we must perform some rules. Rule number 1. Parts of intestine which is sutured to each other should be approximately in equal size. So now I say you technically what I should do to achieve the previously mentioned 5 points, yeah, which we call the main principles. Now look to me. Now hold your hands like the ring. For example, this is one ring. That is another ring. Now I want to connect this big ring with that small one. Is it technically possible? Yes, of course. What should I do to do this? I must to make a lot of folds in this big ring. I should make it smaller, approximately equal to the ring which she showed. And then only I can connect these rings to each other to have hermetical primary apertures. But is it good? Of course, no. Because then I will apply here the sutures and decrease it, I will form a lot of folds. And through these folds, simply content of intestine after appliement of the sutures can come to our side. It is forbidden. It is understandable for you. Let's say primary her and my rings will be approximately in equal size. Thank you very much. What does it mean, approximately equal size? Difference of the diameters will be not more than half of centimeter. Only in that case, I can have complete, normal, enough connection of these two rings to each other. It is understandable for you. You can say me, but what to do if primary, proximal, and distal rings is not enough to each other? Simply close these both rings and apply anastomose side to side. Don't go to the risk, because risk can destroy everything. Close these two rings, apply normal side to side anastomose. Second rule, very important, guys, these two suturing structures both should be movable. That is very important. Write and mark it. Both should be movable. Look, in my text it is written little in nada. It is written that the suture should not be applied by tension. But we write in more correct way. Both will be movable. What does it mean? I show it for you before, and again I want to show. Hold your fist like this. Now we connected these two structures to each other. Now fix your hand and don't move. Just don't move. Now look, my hand is movable structure. Her hand is unmovable. For example, fix. During my movements now, huge pressure will be applied in the suture line. And I will apply the sutures by tension. Thank you very much. You understand me? If one from the suturing structures will be movable and another unmovable, it will be sutures by tension. This tension will have two origins. Origin number one, if she is unmovable, I am movable, how I connected these structures to each other? I must make tension. Cause number two of the tension, if I will be moved after the suturing, she knows, again, it will tense the place of our suture. As I look, guys, the tension is happened due to two problems. Problem number one. Now she is proximal end of intestine, I am distal. Between us there are tumor. We take and resect it. But after resection I have proximal unmovable, distal movable structure. And I have some distance between them. How I can connect them to each other? I must apply tension. Otherwise I should tense the movable portion to unmovable and apply the suture. They say primary, I have the tension in the place of the suture. Okay, but maybe it is not so high. But after also I have problem. I will be moved by my peristaltical movements. She will be fixed. And again in the place of our suture, the big tension will be applied. And finally this tension will destroy our suture line. And we will have insufficiency of the suture. It is understandable for you. Point number three. Bleeding in the place of the suture should be meticulously stopped. Otherwise, between suturing structures, micro or macro hematomas will be formed. And it will be the cause of the inflammation. Many detention to me. What does it mean? I told you that usually, naturally, if it is small intestine, let's take the example of small one, I should apply double layer of the sutures. Little after I will show you how we do it. If I will not stop the bleeding from the margins of the suturing structures, this blood will be accumulated between these two layers of the sutures, will forms the small hematomas, marginal hematomas, which in the future will be inflamed and forms the abscess. They say, remember please, that is very strong rule. Before suturing of anything inside of the peritoneal cavity, you must arrest all bleeding from the margins. Otherwise, in the future, you can have, again, insufficiency of the suture due to the inflammation. Last rule, strongly for the suture of peritoneal structures, we need to use atraumatical suturing material. We must use only piercing needles and predominantly monofilament fibers or threads. Monofilament threads. Now, many detention to me. Let's explain why it is important. Why atraumatical to not make the big holes? Because you know that traumatical one has very big eye, and then you insert it inside of the structures, you make huge hole. And after only part of this hole occupied by the thread. Because usually eye diameter is much more bigger than diameter of the thread. Otherwise, you will insert it inside of it. Why it is piercing needle? Because if you will use cutting needle, you will make the rupture of the wall of the intestine, and again the big holes will be formed in the place of your suture. Why monofilament fibers? Explanation is more than simple. Remember the capillary forces. Between fibers of the polyfilament thread, we have narrow spaces, which is more than enough for passage of the liquids due to the capillary forces. But don't forget that inside of your intestine, there are huge amount of the liquid aseptical content. And it can simply, between these fibers of the thread, come to outside and contactogeneously gives the infection of the neighboring structures. They say, remember please, this is very important to use atraumatical needles, to use round body needles or piercing needles, otherwise we call them, and to use monofilament fibers. Last point, which is common point, we try to connect it to each other only histologically similar structures. That is, guys, not only unique for intestine. As you remember, this is a role of connection of the tissues. Only if you connect it to each other, same structures. Now tell me, please, Ikra, yeah? Ishak. Tell me, please, why we must connect it similar structures, Ishak, to each other? Why not absolutely different structures? For example, why not to suture mucous membrane with muscular layer? Muscular layer with submucous one. Why I must to try to connect it the same structural units to each other? The friend, to start to speak. Why you say? I say I don't know if you don't know. Why you are like I don't know? Some hypnotized person just look in my face. It is more than simple, because only same structures can give the regeneration. We cannot have regeneration between different structures. This is the cause why I connected to each other the same structural units. Okay, now we need attention to, this is what I told you before, guys, about the structural specificity of the intestinal wall. As you can see, upper two layers, it is the serous membrane and it is muscular layer. It is sterile cell structure. By the way, I want to remind you that for esophagus, we don't have serous coat, we have adventitia. This is also necessary to remember, guys. Serous coat is brilliant from the pure point of the view of suturing, because that is most quick regenerated structure. Then you perforated serous membrane, immediately fibrin is originated in this place. For this fibrin, glue. And it gives very firm gluing. They say, remember, please, adventitia doesn't have this kind of the qualities. Unfortunately, due to this specificity, we must apply in the esophagus usually triple layer of the sutures. Why, unfortunately? Because the diameter of esophagus is not so big. They say this is the problem. Double layers is not enough because you understand the food which is passed from esophagus is very rough. It is dry usually, and from inside it can easily irritate it and damage the place of the suture. So usually these persons first times or long times use the blended food to not irritate it from inside the place of the suture. And you make so-called bushing of the esophagus. What does it mean? The special catheters which we inserted inside of this esophagus to mechanically enlarge it. And we do it very long-term time. From small sizes up to the big sizes, we inserted it inside of the esophagus and mechanically we enlarge during the time the place of our suture. Fortunately for us, it is very elastical structure. And during the time we can achieve our goal, we can make it much more wider just by mechanical enlargement. But before this, before you will achieve the necessary size, again, 2.5, 3 centimeters, you must make the blending of the food. The person should use the approximately liquid food to not have here obstruction of the swallow. Is it understandable? For this, remember, please, the 2 layers, yeah, longitudinal outside, circular from inside. By the way, don't forget that there are one more muscular layer. It is the muscularis mucosa. It is the smooth muscular fibers which is located in the mucous membrane. They say this is important to remember. But now 1 minute attention to me. As I tell you before, to avoid the problems of infections and contactogenous spreading of the microbes to outside, we apply double layer of the sutures. And from this double layer of the sutures, inner layer, it is infected layer. Through the all layers, outer layer, it is the sterile layer of seromuscular or serous, just type of the sutures. Now 1 minute. First we listen, then you will write. What is the, let's say, the best benefits of this double layer of the suture? To answer in this question, first of all, I must understand the benefits of each separated layer of the suture. And in combination, I will have the benefits of the both of them together. Then we speak about sterile sutures. What is the benefit of them? And from these 5 necessary rules of the intestinal suture, hermetism, mechanical strength, prevention of the suction, preservation, maximal, which one they provide? It only lasts. They provided only sterility of the suture, but they are not mechanically strong. Unfortunately, they doesn't make the prevention of the lumen. They doesn't make the arresting of the bleedings because they imply, and what is the worst of this suture? They make deformation of the intestine in the place of the suture. Why? Because first 2 layers is tensed, another no. And we have deformation. They say, remember, please, then we speak about sterile sutures. Qualities of these sterile sutures is not enough to apply them like the single modality of the suture. Because surely, after hours, this suture line will be destroyed. Idea is understand? They say from 5 necessary qualities which you show here, it is not hermetical, it is not strong, it doesn't preserve the lumen, it doesn't make arresting of the bleeding, it is only sterile. What about infected suture? Otherwise, suture through the all layers. Otherwise, we call it marginal suture. All these names, it is synonyms. You can say infected suture, You can say suture through all the layers. You can say marginal suture. It means I perforated the wall from first up to the last layer. By the way, I can do it oppositely, from last up to the first layer. For example, I can suture from the lumen to outside. It means, can you hold your two exercise books in the form of the rings? Something like this. Now imagine that I must connect these two rings to each other. Now, usually, guys, then I make this connection, please hold it in this channel form. Usually, I make the suture from outside to inside, from inside to outside. But I can do it oppositely also, from inside to outside, from outside to inside. In that case, I will apply the knot in the lumen of the intestine. Of course, it will be possible only up to the last 2-3 sutures, because last 2-3 sutures will be in very small distance, and I hardly can apply the knots inside of the intestinal loop. By the way, this kind of the suture has the advantage. After then suture will be absorbed, the knot will be just fall down in the lumen, and by the facies will come to outside. Then you apply knot on the serous membrane. There are the chance after to make some irritation of it, yeah, because it is some foreign body. But anyhow, you can see, doesn't matter, am I started from inside and come to outside, or I'm started from outside, come to inside. Anyhow, my needle pass from the infected layers. Now, from these 5 points, which point I will achieve by this marginal suture? All except sterility. It will be very mechanically strong. It will be very hermetical. It will prevent any deformation of the wall, otherwise closing of the lumen. It will completely press the vessels in all wall place, in the place of the suture. It will close the vessels and prevent any bleeding in this place. But it will not be so. Then I use combination of both these sutures together. I achieve advantages of each one, but unfortunately I achieve one disadvantage. I decrease the lumen. Do you understand me or no? This is main disadvantage of double and triple layers intestinal sutures. There are a second one. Who will tell me now what is the second big disadvantage of many layers suture? Let's call it many layers, yeah? It can be double or triple, except the mentioned one, decreasing of the lumen. Who will answer? I will immediately put the 10. By the way, it is very simple. What is the second disadvantage? Then you use combination of both sutures together. I mean infected and sterile. Sorry?
Healing time will be long. It will take long.
Tell me why. Why, in your opinion, healing time will be long? Then you say it is long. You compare it with what? Longer. First of all, you must say longer than something. Because to say long, doesn't give for me any idea. It is longer than what? Than single layer. I don't understand.
From the regeneration point of view.
What do you mean?
It will not be like proper.
Friends, you must be able to explain what do you want to tell. No ideas? Please, guys, please, use your brain. I say you, problem number 1, any next layer of the suture need more invagination. And the invagination decrease the lumen of the intestine. That is, I told you, but unfortunately there are a second problem connected with many layer sutures. By the way, the more layers you will apply, the more harder will be the second problem. As in first problem, by the way. And lumen, the more layers you will apply, the more you will decrease the lumen. Sorry? But what is the decrease of the lumen there? It is exactly abstraction. Okay, guys, time is very short. 1 minute more. If you will not answer, I will give you answer. Abstraction, I told you, dear. Then I say that the lumen is decreased, it means it can be abstracted. Otherwise, why I speak about decrease of the lumen? It's more than simple, guys. Look to me. The more I will have invagination, no ideas. The more vessels will form the angle in the place of the suture. It means the more I will have the problem with supplement of the place of my suture. This is the problem. That's why you must try to explain. Look, guys, that is greatly visible. Now imagine that inside of my fingers there are the soft tube. The more I will make invagination of my fingers to inside, the more angle will be formed in the wall of this soft tube. And of course, this angle can make finally abstraction. And this is, by the way, not less problematical than the problem of the lumen, if not to say more problematical. Because, sorry, what will be happen with any place without supplement? Necrosis. Even if it will not be so big compression for the necrosis, I will not have enough regeneration. Because you understand that this is place for regeneration, but if I don't have high rate of the metabolism due to the bad supplement, I will not have enough regenerational rate. It is understandable for. Now let's make one more. Guys, you must work forever, not only in the practical class, but even in the lecture. Use your brain. Now look, from that point of the view, tell me please, if we will forget about disadvantages of any suture, which suture modality is best if it will be possible to use it like the single suture leg? Infected or sterile? Huh? Infected, of course, because infected suture has 4 qualities from 5. Sterile suture has 1 quality from 5. I think it is the simple mathematics. If I compare which one is best in single modality, I see that the infected is better. But anyhow, I cannot use it as the single type of the suture because it will give the peritonitis. Can I do something to prevent formation of the peritonitis and to use this single layer of the suture to achieve all advantages which is possible, but to prevent the last 2 disadvantages which we have in case of many layers of sutures. First of all, decrease of the lumen, and second, prevention of the bad supplement of the margins. Otherwise, what should I do to make possible the single infected layer suturings of the intestinal walls? Which modalities I will do to make it possible? Question for everybody. Again, I will put the high mark if you will try to answer it. By the way, it's not so hard. Now try to imagine a situation and tell me please, what can I do to make single suture layer, I mean single infected suture layer, possible to use as single modality, not in the combination with sterile one. Of course, it will not be forever. It will be in some special conditions. My question is understandable for everybody. Oh, guys. Maybe you? What? You want to say I must apply interrupted sutures? But what the matter here? Interrupted, separated between 2 sutures. But anyhow, my needle and thread will pass from infected layer. They come to outside, and the place of my knot will be infected. You will come and touch it because you are intestine, and you will be inflamed, and I will have peritonitis. Is it so good? Of course not. What should I do, guys? Ooh, it's so sad. Guys, you lose your brain. It is more than simple. I must to make sterilization of intestine. I must to make the dysbacterious medical decontamination. I must to clean by the enemas. I must to use the antibiotics to kill, destroy all microorganisms. I must to specially prepare it intestine. Parenteral feeding during 5, 6, 7 days. Nothing will not be eaten, only intravenously. But you must understand, guys, that I can do it only for planned surgical problems, not for the emergency. What I will achieve in that case? Sterile intestine, no possibility for the microorganism, not decrease of the lumen, and absolutely non-damage vascularization. Very short time for the whole regeneration. After 6-7 days, I can change the feeding into the normal enteral because I will have complete regeneration in the place of the suture. Technically, it is very hard. You must make the huge preparation, but theoretically, it is possible. Of course, for any emergency cases, this is completely unuseful. If I have the patient with appendicitis, I don't have chance to make any of this preparation because the problem's connected with hours and minutes. And in majority of the cases, of course, I will not have the chance and possibility to make this preparation. But remember, please, this is technically possible. But you must make huge preparations before using of single layer. That's why 99.9% of the cases we use the combined sutures. Again, I tell you, for small intestine, it is double layer of the sutures. For large intestine, it is 3 layer of the sutures. What does it mean 3? It means 1 infected and 2 steriles. As I told you before, you understand that in that case, I will decrease intestinal lumen approximately into 1.5 centimeter. Because I told you before that each line of the suture approximately decrease into 0.5 centimeter. For large intestine, it's not so much critical because if the lumen is equal to 5 centimeter, you understand that even if you will decrease it into 1.5, you will have more than 3. It is understandable. Of course, for small intestine, situation is another. Maximum layer of the sutures, it is double. And in majority of places, you will not have the chance to make end-to-end anastomosis. You will close the ends and, for example, apply anastomosis between the sides of the intestine. Otherwise, you will have the strong obstruction. Imagine the jejunum, which has normally 2.5 centimeter of diameter. And you apply double layers, you decrease it up to 1.5 centimeter in case of end-to-end. Of course, 100% possibility of formation of the obstruction. That's why we don't do it. Is it understandable? That's why once again, remember please, what is the meaning of more than 1 layers? It is, number 1, to achieve advantage of each type of the suture, and number 2, to eliminate disadvantages of, again, each type of suture. Remember, again, I tell you, what is the advantage of sterile suture? Sterility. Nothing else. It's not strong, it's not hermetical, it's not preserved the vascularization, nothing. What is advantages of infected one? All these points except sterility. So then I make combination. I achieve all advantages, but I prevent the disadvantages. For the sterile one, I achieve all necessary qualities. For infected one, I prevent infection. But also, as I told you before, I have 2 problems. Problem number 1, it is decrease of the lumen. Problem number 2, it is problem with the vascularization. That is, unfortunately, complications of such kind of the suture. Write, please, the next name of the topic. It is types of gastrointestinal anastomosis. Gastrointestinal anastomosis. Before, guys, I will speak about a minute attention into the previous slide. There are different kinds of the suture. I told you that in the last hour lessons we will make completely practical classes. And you will see that we can make sutures by hands, we call it hand sutures, or by special staplers, we call it mechanical sutures. We can make the sutures interrupted, and we can make sutures non-interrupted, yeah, or continuous. By the way, in pediatrical practice, mainly, predominantly, we prefer the interrupted suture. Why? Because we understand that the lumen of intestine during the time will be enlarged. Then you apply non-interrupted suture, guys, you fix the place of the suture line. And during the time, we can have, again, possible obstructions here. Of course, guys, for the adults, both types we can use. I prefer to apply, again, interrupted sutures. Non-interrupted has one advantage, yeah? Between two sutures, it makes not so high, but also some pressure. That isn't good and bad. For what it is good, of course, it's much more mechanically durable, but in the same time, guys, the regeneration of vessels can be pressed. Unfortunately, in our life, we don't have something which is unique and good from all points of the view. Everything has an advantage and disadvantage. And according to situation, unfortunately, guys, you must make the choice. If it will be great to have something which is good from all points of view and use it forever, but we don't have such kind of the chance. Now, write, please, anastomos end to end. Anastomos end to end. And look, we need attention into the picture. As you can see in upper part of my slide, it is written that anastomosis between different parts of the gastrointestinal tract can be performed in 4 main types, end to end. What does it mean? I think it's not necessary to explain you, yeah? We make resection. Now, from one side I have proximal end, from another side I have distal end. And I must make surgery, which is called anastomos, or you can call it recanalization. Brilliant. It means now between these two ends, for small intestine and for stomach, I will apply double layer of the suture. For large intestine, I will apply triple layer. And by these layers of the suture, I must make surgery, which she called recanalization. Absolutely correct. Second type of anastomos we call side to side. These two methods together, guys, forms 99% of all anastomosis. End to end, approximately 40%. And side to side, approximately 60%. If we will speak about whole of them, yeah? Last two methods is very seldomly used. It is end to side and side to end. What does it mean? First part of this term show proximal portion of anastomosis. Then you say end to side, it means proximal end, you connect it with distal side. Then you say side to end, vice versa, proximal side, you connect it with distal end. For example, we have gastroenteral anastomosis, side to end to side. Or for example, there are the tumor of the iliac-sacral angle. You remove this iliac-sacral angle. Now you connect it ascending colon and you connect it the ileum. And you will make connection now end to side. End of the ileum, you connect it with the side of the ascending colon. You can say, but sir, what do you say before? Yeah, tangent, because one will be mesoperitone. Here it's not so important, guys, because you understand that small intestine is so large, I mean it's long, that no any pressure will not be applied in the place of this anastomosis. You don't need tension. Tension usually will perform if there are short pieces of the gastrointestinal. Here we have 5 meters of the small intestine. And of course you understand that no any tension here will not be applied in the suture place. It is understandable for you. Let's speak about technique. Right, please. Step number 1. On the posterior lip of future anastomosis, we apply sterile line of the sutures. Firstly right, then I will draw and show what does it mean. Once again, on the posterior lip of future anastomosis, we apply sterile line of the suture. Now look in the picture. What does it mean? This is my 2 intestinal structures, intestinal organs, which I need to connect it to each other. First of all, guys, in my previous lesson I told you that we can turn each part of this intestine maximum into 120 degrees. Not more to not press the mesenteric vessels. Why I do it? Because generally, you know, yeah, I cut more for the contact mesenteric margin and less for the mesenteric margin. That's it. Primary, I have something like this. This is mesentery. Primary, I have something like this. So now I must turn these loops to each other to make connection in such a way. This is 1 and this is 7. Okay, first of all, it is enlarge the aperture and decrease possibility of the constriction in this place. And secondary, it is gives the good alignment of these 2 equal parts to each other. Now, for example, this is these 2 rings. Now look please, margins which is far from you, we call posterior lips of the anastomosis. Margins which is looped to you, we call anterior lip. Again, I will take my, for example, register and will form these 2 rings, which I need to connect it now to each other. Now, it is in front of me. The margins which is far from me, we call posterior lips. Now I touch them to each other. Margins which is near to me, I call anterior lip. Let's say this is anterior lip of anastomosis, that is posterior lip. Now what I will do as the first modality, in this posterior lip of anastomosis, approximately 3 millimeters far from the margin, I will apply serous sutures. I means my needle will pass only through the serous and muscular layers. And by this I will suture half of my ring. Ring is 360 degrees, that's a 180 degree from up to down. I will suture on the posterior. I will apply sterile layer of the suture on the posterior lip. It is absolutely sterile. If you will look from back side, you will see sterile suture line. It doesn't come to the lumen of intestine. It's not infected. Modality number 2. Now in this posterior lip, I apply the marginal suture. Brilliant, guys. If you will look now from back side, you will see complete double layer suture. Of course, for large intestine, we will apply 3 layers. After the first sterile, we will do 6-8 centimeter far from margin. Then we will apply second sterile, 3 millimeter, and then only we will apply infected. But because I give the example of small intestine, let's say 1 sterile, 1 infected. Now from back side, I have complete suture for the posterior lip. Step number 3. Now in anterior lip, I apply infected suture. Now look to me. After suturing of posterior lip, I touch the anterior lips to each other, and first of all, 3 millimeters far from the margin, I apply infected suture through the all layers. Step number 4, I close this infected suture by sterile one on the anterior lip. Again, 3 millimeters far from the previous suture line, 3-4 millimeters. I apply the second line. That's how I look. What I do for anterior lip, I apply infected suture, then I close it by sterile. In the back wall, vice versa. First of all, sterile, then infected. In anterior, first of all, infected, then sterile. Now, if you will look to this whole circle, you will see 2 rings inside of each other. Ari ninja. Inside of the outer ring. Asani. Բայց դու որտեղ ես հիմա Okay. Now look, inside of outer sterile ring, I will have inner infected ring. And inner infected ring from all the sides will be closed by the sterile one. Idea is understandable for you. Very well. 1 minute attention to me. What should I do in case of end-to-end anastomosis? Generally, everything is safe. Now look to me. For example, that is one end, and that is another end. First of all, both these ends, I will close for small intestine by double layers of suture, for large by triple. It means firstly infected, then sterile. Yeah? Hips is closed. Now I will decide the size of my communication. For example, I will apply 4 centimeter communication. It means if I make double suture, my intestinal wall incision will be 5 centimeters. Because double layers will eat one from this 5 centimeter, finally I will have 4 centimeters. Yeah? That's what I should do. Now look please here. First of all, if my incisional size is 5 centimeters, first of all, between these 2 parts of intestine, I will apply approximately 6-7 centimeters sterile suture. Look, we don't have until now the lips, but sterile suture of the posterior lip we apply. Why you apply it more than the future side of the incision? To make hermetization from up to down. Now you apply here intestinal clamps, yeah, to prevent passage of content. Take the scalpel and 3 millimeters, 4 millimeters far from the from the first suture line, you open the loop of the intestine. As you can see, my first suture line is longer than the incision, to close it and from up to down. Now you can see the lips of my anastomosis, posterior lips and anterior lips. In the posterior lip, first line is applied. Now I will apply infected one. Then I will come to the anterior lip, I will apply infected, then I will apply the sterile one. And finally I will have communication like this. One. Second. And here we have communication. Idea is understandable for you. Thank you very much. Let's finish. Give me please one pen.